being with us, and over to you.
Great. Thank you so much, Stefan. It's really great to be here, and it's an honor, obviously, to kick off this important set of academic activities. And I would just start by saying that, of course, we all are all over the world really very interested in this particular condition, syndrome that is affecting so many people out there. And what I would like to do is just to talk about not just my perspective, but in terms of where we are in this field and what we anticipate that needs to be done as we continue to tackle this important problem everywhere. I'll start by saying that I have no conflicts of interest related to this presentation. Now, I have worked primarily in the field of diabetes, obesity-related disorder as an endocrinologist here in the Harvard system for many years. And I would say that despite all the great advances that we've had in the field of diabetes, we continue to fall short in achieving treatment targets. What you all see here in this particular slide is the fact that only, as you can see here on the right, 1 in 4 individuals diagnosed with diabetes in the United States have achieved the basic treatment targets that include good A1C, good blood pressure, non-HDL cholesterol control, and non-smoking. Now, notice that those targets are actually not the most strict ones. If we lower the A1C from less than 8 to less than 7%, for example, or the blood pressure to less than 120 or 130/80, of course, the proportion of people achieving targets would be even lower. The point that I'm making is that despite the advances with medications, with technology, with knowledge, we are not having the impact that we should have. Most people with diabetes are not doing very well. And I think that applies not just to the United States, but or to people basically everywhere around the world. Now, one of the other big pieces that we see is that the money that is used in healthcare, in diabetes care, is not used in the best way. We did a study here in the United States in which we looked at the Medicare population. So these are people above the age of 65 or some with low socioeconomic level that are covered by the government. And we found that 70% of all the money that is available in the diabetes care arena is spent in only 15% of people with diabetes. Now, who are these people? Well, obviously those with complications of the disease. And what's really very expensive is dialysis and cardiovascular interventions and surgeries and stroke treatment and blindness and amputations. So we're using the money in late stages of the condition and not for the early diagnosis and interventions to prevent these complications. And many of these individuals are those that belong to high-risk populations, something that I have been working on for a number of years, people with very high risk, either by virtue of their race, ethnicity, and or socioeconomic factors. So we're not using the money in the most intelligent way, I would say. We're still waiting for people to develop advanced stages of all these conditions to intervene. And that's obviously not the best way to go. Now, I have reflected on this for a long time, and I always come back to this triad of what we call the healthcare system, the healthcare professional or provider, and the patient. And then we obviously still, and will continue to do that, interact with patients, and we try to provide the best care that we want, that we can in terms of improving their lifestyle, prescribing medications, asking them to test their blood sugars regularly, etc. And that's something that we, of course, will continue to do. But based on what I just said about the fact that most people are not achieving targets, the question is, what are we missing? And this applies also to the cardiorenal metabolic syndrome. Most people are not doing that well. Well, I think that on one hand, I think that the patients do have more than just the body, right? Everybody, we all are, as individuals, have the psychological, social, cultural aspects. And we are not very good at addressing that. To be very honest, when we go to medical school and in our training, we are really good at the biological side of things, but not about the other aspects that ultimately determine a lot of what is going to happen with every individual throughout their life. So we as healthcare professionals need to obviously look at some of these aspects. We have our own biases, our own interests. So we need to think about this in a more comprehensive way. And the problem is that in most healthcare systems around the world, we have this reactive model, which means that we just wait for people who are sick to come to see us in clinic. We try to fix whatever may be happening, and we send them back to their homes, to their community, and we do not have proper follow-up when they're not with us. And this system is helping some people, but not everybody. So as we think about what's happening now and where we're going in the management, not just of diabetes, but cardiorenal metabolic disease or syndrome, it is important to reflect on all these three different aspects. And I would say that over the years, perhaps because of my frustration and not being able to help many of my patients, I created a few years ago this list that I call the A to Z list for the management of diabetes and cardiometabolic disease. And I won't go through all this, but just for you to see the number of factors that have been well documented to impact cardiometabolic disease, diabetes care, and overall health. And I would just ask you, how many of these do you routinely assess in your clinical practice? And I would say that certainly some of them, but probably not all. And I think that, again, if we are thinking about the comprehensive approach for the evaluation, for the management of all these conditions, we need to consider that. But let me spend some time on what I think are the two most important ones here, which is on one side, the biology that we know and what we have identified. And then, of course, the social aspects that I mentioned before that are equally important. Now, from the biological perspective, I think that we have come to understand that, again, if we start from type 2 diabetes, we used to have a glucose-centric approach and trying to just understand how blood sugars were elevated in people with diabetes, and that was our focus many, many years ago. And then more recently, as you can see in the slide, we now recognize that there are multiple organ systems that are affected in anyone with type 2 diabetes, starting from the brain that regulates appetite and satiety, obviously insulin resistance at the level of the skeletal muscle and the liver, obviously the decline in beta cell function. Now we know alpha cell function is also affected, incretin dysfunction, and even renal glucose handling, which is, of course, the basis for some of the recent interventions like the SGLT2 inhibitors, etc. And we know that in most people with type 2 diabetes, all these conditions, all these abnormalities happen. The only one that happens in absolutely everyone is, of course, beta cell dysfunction. Otherwise, people would not have hyperglycemia. But as you can also see on the left-hand side, we have the evidence that there is a genetic predisposition for the development of diabetes that happens differently across populations around the world, but also lifestyle factors, weight gain, inadequate nutrition, lack of physical activity, and all those are related very closely to socioeconomic and cultural factors that influence the development of type 2 diabetes and eventually their complications if diabetes is not well treated. But we're now at a point when we have talked not just about diabetes and obesity, but the whole complex of what we call the cardiorenal metabolic syndrome. And you can see that this is a systemic disorder characterized by pathophysiological interactions among metabolic risk factors like chronic kidney disease and the cardiovascular system, leading to multi-organ dysfunction and a high rate of adverse cardiovascular outcomes. And I think it's important to recognize that this is not just for people with established cardiovascular and renal disease, but people at risk for these conditions as they move along. So in a more simple way, as you can see there in the middle of the slide, a health disorder due to connections among heart, kidney, diabetes, and obesity leading to poor health outcomes. And this is now the most recent comprehensive approach to the cardiorenal metabolic syndrome, dividing that in different stages, starting from stage 0, which is hopefully where we all like to be, which is no risk factors. We have a healthy lifestyle. We have the ideal body weight. But then, as you can see, there's a progression. Stage 1 relates to the excess of fat in the body. Stage 2 is adiposity plus now some risk factors for cardiovascular and kidney disease like high triglycerides, the so-called metabolic syndrome, hypertension, could be pre-diabetes or type 2 diabetes, and increased risk for cardiovascular disease. And then stage 3 is the subclinical cardiovascular and 𝐃𝐚𝐬 syndrome with subclinical atherosclerotic cardiovascular disease, perhaps subclinical heart failure. And then stage 4 is when people have established conditions. And at every single point throughout this progression of this syndrome, we can intervene. Now, it makes sense to think that the earlier we do that, the better. I don't think that we're doing that great at the present time, even though this is not a new concept. For many of you, we have talked about, this for many decades now, about how these things are correlated. But I think that the nice thing that is happening now is that we're putting things together now in a more comprehensive way across disciplines in medicine. So as an endocrinologist, I see this as a more comprehensive way. The same thing for a cardiologist, for a nephrologist, for a liver specialist, which, by the way, the liver is missing here, which I anticipate should actually be there as well. But, for internists, primary care physicians, family physicians, this is the concept that we need to have in our minds as we move along in order to do a better job there. Now, in the United States, believe it or not, some of the recent data show that about 90% of individuals in the country somehow meet the criteria for cardio-kidney metabolic disease, obviously at different stages. If we put together those that have already overweight or obesity, plus any of the other risk factors, you can see there the distribution. So it is something that is happening very, very commonly, not just here in the U.S., but across the world. And one of the things that we need to do is to really be aware of how these conditions are connected and how early they can be present in individuals as we move along. And central to this is obviously adiposity. And we now know that the adipose tissue is the culprit for a lot of these different things that we are seeing in this syndrome. As you can see on the left-hand side, we have the healthy adipose cells. That's where we want the fat to be stored, mostly subcutaneous tissue. But as we continue to gain weight, of course, that's not enough as the storage place for the fat, and then the adipose cells continue to get saturated, and it's the visceral fat, mostly in the abdominal cavity, that gets saturated, and that creates an overflow of fat that needs to now go somewhere else because it is not possible to be deposited there completely. And that's basically the overflow that we see about fat traveling to the liver, to the heart, to the pancreas, to the skeletal muscle, and creating a lot of the conditions that we are discussing today. So I think that it's clear that one of the important strategies is to identify this early and not to consider that it's just benign to be overweight. It is something that is related to a lot of different issues. And that's the reason why, again, we have moved from that glucocentric approach in type 2 diabetes to think that obesity is actually very closely related to that. And that may actually be the primary target in terms of type 2 diabetes management. Certainly, controlling blood sugars will continue to be important, but it's more than that. It's about looking at how all these abnormalities are correlated. And that's the reason why, as you can see on the left, if we target obesity, early weight gain, and modifying this condition, we may actually improve and decrease the impact downstream of many of the other conditions that we're discussing today. Now, I have personally been involved in different studies over the years in regards to early intervention, diabetes prevention, cardiovascular disease. And we found many years ago that when we look at endothelial function, it is clear that it is abnormal in people with type 2 diabetes, as you can see on the right side, but also in individuals at risk for type 2 diabetes, like people with prediabetes, impaired glucose tolerance, and also even in relatives of people with type 2 diabetes. So these are people who have normal blood glucose levels, normal blood pressure, normal lipids. It shows that they have family history of type 2 diabetes. Now, in this case, the relatives, the mean BMI was about 26, so overweight. It doesn't take too much to start seeing abnormalities in metabolism and in endothelial function in individuals across different populations. And one of the challenges that we have in the field is that now we have a lot of children who are overweight or have obesity, and this is creating a huge issue because this syndrome of cardiorenal metabolic disease is starting very early in life. And I think this is something that we need to really pay very close attention to. We did a study in overweight and children defined as having their BMI above the 85th percentile for their age and gender compared to healthy, lean children and adolescents. So the mean age is about 14 years. And as you can see here, those in the overweight category, which by the way, did not have diabetes or hypertension, etc., just overweight or with obesity, they had so many abnormalities in their endothelial function, markers of vascular inflammation, including the white blood cell count, as you can see at the center of the slide in the lower panel, where even though within the normal limits, that's higher than what you see in healthy children, suggesting a chronic inflammatory process that is happening very early in life. So we're not surprised anymore that we now see very young individuals in their 20s, their 30s with type 2 diabetes, with hypertension, dyslipidemia, and even cardiovascular disease and renal disease. So this is something that, of course, should really be at the center of our strategies in clinical practice, identify people as early as possible, and obviously offer whatever we can from both lifestyle modification and, if appropriate, pharmacological interventions. So that's where we are with the biological aspect, but also from the socioeconomic perspective. And this is why I wanted to really bring that to your attention, because it's not just about clinical guidelines and implementing therapies. It's about looking beyond that particular aspect. And we now know very well that for most diseases that we treat, it is what we call the social determinants of health that are absolutely important. And as you can see, as defined by the World Health Organization, these are the conditions in which people are born, grow, live, work, and age. And these are circumstances that are shaped by the distribution of money, power, and resources at global, national, and local levels. And these are responsible for health inequities as well, which are the unfair and avoidable differences in health status seen within and between countries. So this is obviously something that we have known for a long time. And this is the usual sort of controversy. What's more important? Is it, the genetic factors? Is it what happens in people's life? It is the environment? Is it the medical aspect? I think that they all are interrelated, but clearly the conditions under which people live will determine a lot of what's going to happen. Actually, there are studies that show that probably 60 to 65% of the outcomes in anyone's health over time are determined by social conditions and not necessarily by genetics, probably not even depending on what we do as clinical care providers. So I think it's important to recognize that that's important. And just to illustrate how this is related to social aspects, I want to show you this example that I think is really fascinating. in terms of how in type 2 diabetes, there may be different phenotypes as how people present with diabetes. Not everybody has the same clinical characteristics. And you may be aware of this publication from a group in Scandinavia some years ago about the different clusters that could be identified. Again, I don't think this is ready for prime time and to be done everywhere. I think that we need more studies, but I think that it illustrates that there may be differences in how type 2 diabetes is presented. And here we have different measurements like age, BMI, A1C, antibodies, and then calculations that derive from insulin and glucose like HOMA. And based on that, people are characterized and divided into different clusters, as you can see on the right, like whether people have a predominance of insulin resistance or insulin deficiency, and then whether obesity or age are driving these particular conditions. And again, this is something that was reported a few years ago, and now there's studies in different places around the world. And, you know, a group in Mexico that I've been collaborating with, I'm originally from Mexico, by the way, have good colleagues and friends there. And what they did was to assess which one of these different clusters was more common in the Mexican population. Now, in contrast to what has been reported here in the U.S. through the National Health and Nutrition Examination Survey, in which the age-related diabetes or obesity-related diabetes are more common. In Mexico, it was the severe insulin-deficient diabetes that was more common. And then in a study in which I participated, we actually looked at the fact that this may be, it is related actually to the socioeconomic characteristics of the population. In Mexico, there's a gradient that the northern states are wealthier than the southern states. So the poor conditions are in the south of the country, and that is where there's more insulin deficient diabetes. Again, I think this has been well demonstrated in many countries around the world, and I think this is where we need to go in the future also with the cardiorenal metabolic syndrome, is really understanding how these conditions differ across populations so that can guide our interventions. From the genetic perspective, I think that we still have a lot of things to do, but also how these impact clinical characteristics. I anticipate this will continue to be done. So I'm sure that you all in your corresponding regions around the world and in your countries are thinking about how all this applies to your own population. And I think that's really the best way to go. Now, talking about the environment, I just want to also share with you this publication that I was also part of in our collaboration with a group in Italy in terms of the presence of micro and nanoplastics in atheromas and cardiovascular events. And the reason why I want to mention this is because, again, this has to do with social characteristics, with the environment, where we live and how we live and do different things. Now, we all know that micro and nanoplastics are basically everywhere, right? It's not just in plastic containers, but in the water. We can actually breathe micro and nanoplastics. They could be in water pipes, in constructions, in so many different places. It's really hard to be away from that. But one of the things, and this is the reason why this article received a lot of attention, and we published that last year in the New England Journal of Medicine, is that the group in Italy identified patients who had atherosclerosis at the level of the carotid artery. And the artery was blocked by more than 70%. So they required intervention and arterectomy in order to correct the obstruction. All the patients were exactly the same from the clinical perspective. But then what we did was to study whether the atheromas that were extracted from these individuals had or didn't have micro and nanoplastics in the analysis. And then based on that, we created two groups, those with and without micro and nanoplastics. No differences from the clinical perspective that were really significant. And then what we found is that those with micro nanoplastics did have more markers of inflammation locally, which is expected as a result of more inflammation. But this is the punchline of the study. when we follow people for the next 3 years or more, those with micro nanoplastics had a much higher incidence of cardiovascular events. Now, I cannot say that this is a cause-effect relationship because is just an association. But wow, this is just bringing to our attention the fact that what happens in our environment may actually be more important than we think. So just to finish up, I think that it is important to think about where we are now. I think it's great that we have a lot more understanding and strategies for cardiometabolic disease. But in order to move forward, we need to think about teams. We need to think about how we move away from just the physician-centric approach. We need the participation of different people that can help us addressing the biological and social aspects of cardiometabolic care, as you can see here on the slide. I personally see patients not in the beautiful building that you see on the left, that is the Brigham and Women's Hospital in Boston, but I go to a community health center. It's a small place where I actually feel closer to my patients because I am in their own community and I better understand how they live and what they do and what they are exposed to. And I think that this is something that we need to think about, how to get closer to our patients as we move along. We have clear guidelines about the great benefits in terms of lifestyle modification. These are from our American Diabetes Association group. And clearly medications that have come to revolutionize the management of cardiometabolic disease and kidney disease, weight management, glucose management, as you can see on the right. So this is something that everybody should be aware of, but the actual implementation of the guidelines is important. So it has to do with what the government and policies really do. It has to do with education in different schools, professional organizations, community-based activities and programs. Who's paying for all this? Insurance companies, pharmaceutical companies, and ultimately media out there that should really bring accurate information to everybody. So ultimately, we need to work together in order to do that. So what I anticipate, Stefan, just to finish here, this is my last slide, is to just project that as we go along, we need to think about better understanding how this affects different populations across the world, maybe starting the early identification and intervention, maybe better screening strategies in populations, how to identify disease at an early stage. And I think that the regular and constant screening for social determinants of health should be embedded in clinical practice in order to do a better job to put all these different things together to help as many patients and families out there. And with that, I finish here, and I thank you very much for your attention. And Stefan, I'll turn it over to you for the final part of this presentation. Thank you very much. Yeah, so thank you, Stefan. That's probably the most important question. How can we transform healthcare in order to properly address cardiorenal metabolic syndrome or disease? And I think that if we think about what's happening right now, we're just waiting for people to come to us. We see them for a few minutes. In best case scenarios, we see them for maybe 15 minutes, and then we don't see them again for, 3 months, 4 months. So it's a total of maybe 1 hour per year that we interact with a patient. It's totally unrealistic to think that we're going to have great impact if we continue with that model. We're helping some people for sure, but we're not helping everybody. So what we need is to think about how can we be in touch with people when they're not with us in the clinic. And again, it's not the physician that needs to do that. We need to create teams that could be in touch with patients when they're not in the clinic, in the community. Stefan, we learned this from the COVID-19 pandemic. We couldn't see patients in the clinic. We had to call them. We had to do telemedicine. We had to bring things to their community to try to interact with them. My concern is that now that everything is back to normal, we are going back to that same reactive model. And I think that's a mistake. We should think about what did we learn from the pandemic that we could still implement there. And I think that that has to do with that connection when they're not here. So a proactive model, which would be the opposite of the reactive model, would be to think about the chronic disease management approach. And it is not just this very sporadic point, of contact with the patient, but really have a team that could be in touch with the patient. Again, it's not the physician because we don't have time. We're not enough. but it's really creating teams that can help us be in touch with patients when they're not with us and trying to do things in a community-based approach. I think that's really what we need to consider in order to tackle this more effectively.
I mean, team, that's an interesting aspect for all our watchers, listeners here, attendees at the Congress. The team means the physicians, the nurses, the technicians, other social workers. How much do you see actually technology solutions being part of this? Because in the end, let's face it, the human cost is for many healthcare systems a really important factor. And there is the never-ending increase in healthcare expenditure. Efficiency increases need also technology solutions. So where do you see that going? If you think of all the screening activities, for instance, that are needed, is it always humans that need to do the screening?
Yeah, that's a great point, Stefan. And I think that technology can be very helpful. I mean, we will still need, obviously, the personnel and the team to be there. But sure, I think that we could actually work intelligently with technology to help us implement some of these things. So, for example, some of the screening activities could be done now with artificial intelligence, maybe telemedicine in terms of trying to reach out to individuals. I have always thought, everybody almost around the world has a cell phone. And I think that we could try to find ways in which we can gather information, provide education to them. So I think that there is a chance there about moving away from the traditional approach of just seeing patients in the clinic and thinking about other aspects. You're right that in the end, positions are not funded. This sounds really great, but then administrators say, no, we cannot pay for social workers and more, people in the community and pharmacists, etc. But really, there are models out there that show that if you do that, it's actually better in terms of outcomes and preventing different conditions. In the end, I go back to what I said earlier. We're spending too much money on late stages of all these conditions. If we move some of that spending earlier, I think that's probably much better for every healthcare system and ultimately for our societies.
So if you think about the stages of catechitic metabolic syndrome, then really the key is already stage 1, right? Excess dysfunctional adipose tissue, if you like. And if you think about this, a person starting to look online for bigger sizes of clothing, a person basically where the cell phone being in the pocket counts the number of steps, counts or assesses the average speed, and let's say the speed goes down. Let's say you have some search terms in your Google about symptoms of fatigue and shortness of breath. If that actually, the stage 1 is definitely as scary as it may sound, something that is very easy to assess without even a single human being, right? With all the modern technology we already have.
Yeah. And I think that that's where we need to go, right? So think about the future of this. I think we're doing great now in terms of identifying interventions for later stages, but how can we convince individuals that having some extra kilograms or pounds is actually not healthy? And I also have to bring this, Stefan, that from the cultural perspective, because I'm originally from the Hispanic Latino community where, again, not just there, but in many other groups, if you have a few extra kilograms per pound, you actually feel that you're healthy, you're great, you're robust, you're eating well, you're actually, having a good life. But there's some evidence, of course, that, slight increase in weight may translate into some detrimental stages. I have been, for example, a co-investigator in the diabetes prevention program, the DPP, for many years, in which we demonstrated that you can prevent type 2 diabetes if you have pre-diabetes. And something for everybody to remember is that what we found is that 1 kilogram of weight loss reduces the risk for type 2 diabetes by 16% in individuals with pre-diabetes. So it's not about, losing 20% of weight or gaining 20% of anyone's weight to see changes in metabolism or vascular function. Small changes could be impactful either way, if you gain or if you lose the weight. So I think that there are strategies that we need to implement early on in trying to really bring this to people's attention.
Well, I think this is a great opening session. Thank you so much for this perspective. We really have a lot of things to do, a lot of things to learn, and this conference is supposed to help it. And thanks again for being with us here at the opening session of the Congress and giving this fantastic keynote lecture. We will continue with the program, and thanks everybody for watching and being part of this. See you soon in the next session, and see you soon at the next also in-person Congress, wherever it is around the world.